Assalamu alaikum, everyone. Welcome in the last but not the least lecture in this series. Please join me to welcome Dr. Ayman AlSuhaibani. Dr. Ayman is specialized in neuromuscular rehabilitation, and he is the medical director of Rehabilitation Hospital in King Fahad Medical City. Welcome, Dr. Ayman, and thank you for accepting our invitation. The floor is yours, Dr. Ayman.
طيب السلام ورحمة الله وبركاته. يعطيكم العافية جميعا. I extend my thanks and appreciation to Dr. Muhammad Jamil. Actually, he's the engine behind this series of events over the last week, and supported by Physical Medicine and Rehabilitation Department at King Fahad Medical City. And thanks for inviting me today, and thanks for all the participants to join us. I know it's a weekend and it's evening night, and yet, mashallah, more than 30 people are joining. I'll try my best to share my limited experience over the last years, to discuss about the challenges I have faced and how I overcome these challenges, and what I believe as of now, how we should approach it. And also, it's important to say this is a learning process. These challenges sometimes, or most of these challenges I'm going to highlight today, we haven't seen it in the textbook or references, but we are facing it in real life. And we are learning through the process how to approach some of these challenges. We're learning from colleagues, the patient, and ourselves from time to time. Before I start, I would like to share a story. During my residency training, I had a rotation in cardiology. And one of the cardiology consultants used to say, it took me 20 years to ask the right question, to ask patient right question to know if they have palpitation or not. At the time myself, I thought he is exaggerating. When I return, I start practicing independent practice. With time, I have learned that he might be right. Many of what we believe it's an easy, straightforward, we need to know how to approach it in a way that match our patient's need, our patient culture, our patient belief, and our scientific knowledge and evidence-based. And starting from that, story and the experience, I'm still learning on a day-to-day to face and to handle the challenges I face on a daily practice. We will try to have some interactive discussion throughout the session today, and learn from your experience and suggestion as well, because it's more of about learning from each other today. Okay, it's important to highlight that, Yes, it's important to highlight that we as a physical medicine rehab, we are a center in the neurological, most of the neurological cases care, starting from the ICU all the way to the community participation. Why I highlighted that? Because it's very important for all of us to know that we have a role in a patient journey throughout the different part of the patient's disease course. Sometimes when we talk about acute ill patient, such patient who is in ICU, we think our role is more of triaging to see a patient and assess if he's a candidate for rehab or not, while we do have other roles in easing patient care, improving quality of life, preventing complication, investigating the possible complication. at that stage before the patient become ready to start the rehab. And that's very important, crucial for all of us to remember that we have a role in patient care throughout the patient journey. And many neurological diseases, especially the chronic one, are not just a diagnosis, they are lifelong challenges to your patient, affecting their function, their independency, and also their dignity. Patients are struggling on day to day, and we need to understand what's their struggle at different level throughout the disease course. And from that, if we have a good rapport with the patient, we ask the right question, we can help the patient at a different level and improve. I wouldn't say many diseases, there is no cure or recovery for them, but at least we ease their life and minimize the challenge they are facing. And also it's important before starting your rehab plan to know the diagnosis of your patient. And that's also, I will comment on it later, because having the right diagnosis will help you to know the prognosis, the expected prognosis of such disease. And based on that, you will plan your rehab goals and treatment and intervention according to the diagnosis and the prognosis that known for the disease. At the same time, knowing the right diagnosis also help you to know if there is a new treatment for such disease. As you know, many of neuromuscular diseases and different myopathies, we didn't have a treatment for them before, but currently there are a few of them, and few development with the gene therapy, and some of them now there are disease to at least stabilize the patient condition. And some they have promising results where patient function may improve. It's very crucial for you to know that before enrolling a patient in a rehabilitation and the long-term plans without addressing the medical management if there are any. Now to come to the next question. If patient is undergoing diagnostic workup, can rehab start or not? I want to hear your thoughts, ideas. If patient has no final diagnosis yet, and he is undergoing different diagnostic workup, should we start the rehab plans and plan the goals for these patients, or we should wait until the final diagnosis?
Yes, Dr. Ayman, can I answer?
Yes, go.
From my side, I think it's and usually, for most of the time, it's very good to start earlier, even before diagnosis. You know, to reach the diagnosis in many centers is not so easy, because many factors, either the diagnostic facility and investigation, or the disease course by itself. But the most important to at least like characterize the disease. Is it upper motor neuron, lower motor neuron? Rule out some precautions, like if patient suspected to have myopathy or inflammatory myopathy. Other than, I think it's good to start patients.
Yeah, excellent. I totally agree. I mean, it's not a solid yes and no. And I see some answer also here. They say maintenance. It's not only maintenance. It's depend on the disease and what's the expected diagnosis. Most of the diseases, they have primary diagnosis or a group of diagnoses. And the further workup is to confirm which diagnosis the patient has. It depends of if the patient diagnostic workup will varies on the management. Like patients diagnostic workup will confirm if he's having a GBS versus other polyneuropathy. This is a crucial because knowing that if it's AIDB, we have to start the acute medical management, delaying that will impact the patient's outcome. Versus a patient who has myopathy, now we are questioning, is it limb-girdle muscular dystrophy or facioscapulohumeral dystrophy? Regardless which one is turned to be, there isn't much difference in terms of the management plan and the rehab goals. That's why I say it's depend, but the key here, if the diagnostic workup is crucial and the suspected diagnosis has to be managed on a timely fashion, then I'll advocate start with the acute rehab team while the patient under the primary service. Talk about the admitted patient. If the suspected diagnosis won't change much in terms of the medical management, then delaying a rehab will impact the patient function and recovery, and we should start as early as possible. طيب.
السلام عليكم.
السلام ورحمة الله.
السلام عليكم.
السلام ورحمة الله وبركاته. تفضل دكتور.
دكتور أيمن بارك الله فيك.
حياك الله.
From my side or my point of view, usually we know that in rehabilitation medicine we have our own assessment and diagnosis, and it is based mainly on the holistic view of the patient, and it regards with mainly with the functioning issues. So we can start according to our assessment immediately our rehab. No need to wait for other medical diagnosis. This is my point of view. Thank you.
Yeah, exactly. Thank you, Doctor. Yeah, yes, you're right. We should start as early as possible, but maybe I will highlight is to take over, transfer patient from the primary team under inpatient rehab facility or under a primary rehab physician. We should make sure there isn't a significant pending workup or diagnostic workup that may result in a significant change of patient's medical management. If the expected workup won't significantly change the medical management, patient can be transferred to a rehab facility or started to be under the rehab physician while continuing the diagnostic workup. طيب, when you approach a patient, I put this slide because most of us we believe that history is the easiest part, and all of us we are mastering taking history from a patient. Believe me, still I'm not saying all the time, but few times we're still having difficulty getting the accurate information from a patient if we do not ask the patient the right question and approach the patient with the right approach to give a patient opportunities to raise their concerns and address it during that visit. Usually when I have a patient, before taking further information, I start to address the patient concern, why he is here, and always I prefer open-ended question because that will tell you a lot about what's the patient's priority for this visit. Unless we ask that question, we may not understand what's the pressing matter for this patient, and we go and manage something else, which is for a patient is not a priority and it's not that important. And patient feels at the end is not satisfied and we did not listen to him. For that, open-ended question, asking the patient, how can you help you, why you are here? Then the patient will open up, give you the statement why he is here, and try to summarize it and say, is there anything else you want us to address today? This is the first 1 or 2 minutes of a patient encounter, he will list 3, 4, depend 5 to on average 3 to 4, not more than that, based on my experience, concerns that a patient has. Then we ask about history of present illness. We take these concerns, we ask detail about these concerns, but most of the time, if patients is new to me, I will ask about the disease in general and the course of the disease and the patient journey throughout the course of the disease. Because that also will summarize a lot for you, and you understand what did the patient try before, what the previous experience he had, there is any negative, positive experience patient had before. And all of these are very relevant and crucial information for you later on to address. When I ask about the course of disease and the patient journey, I will go and ask details about his concern, or we call it a chief complaint, and try to get the relevant information related to that. And the same approach, when I ask about functional level, we have a FIM. Most of the time we like to ask a question about function level relying on FIM, but all of us know FIM has a limitation, and also some patients concerned are not addressed by FIM. FIM is very important and very excellent outcome measure to assess patient function, but it's not accurate, and you may miss something that's relevant to your patient. And my approach when I ask about the functional level, it depends on the patient. If I find a patient who is almost totally independent, he might have some mild limitation, I will ask, okay, is there anything that you need help with in your daily life, or any of your daily tasks that you cannot do by yourself and you need someone to help you with? That's an open-ended question. We'll summarize everything instead of asking like, how's the dressing, how's the transfer, I just ask, okay, your daily life, are there things that you need someone to help you with, or you can do everything by yourself? Sometimes if the patient he didn't get it, I'll ask him, okay, if you are alone, no one else at home, are there things that you need to wait for someone to come and help you because you cannot do it yourself? I found that question very useful to address the minor things sometimes. We believe the patient is totally independent, but there are minor things on his daily life not addressed. On the other hand, someone is having significant disability and it seems that he is relying on a family member or caregiver for most of his daily tasks. I ask the opposite question: what are the things that you can do yourself without help? Because maybe it's not part of the FEM, but these functions that patients can do independently are very important for him, and you can build on it to improve it and make it better for the patient. But asking functional history, it has to be beyond only FEM. Documentation and the FEM score is a universal. It's very important, crucial, because it's a measurable. We can compare it from today to next follow-up. But asking these open-ended question will make your patient open up and understand more about your patient needs and concern and his current situation, so you can help him. When it comes to the examination, of course, we have to do the physical examination as we taught how to do it, both neurological, cognitive, and musculoskeletal. But I like to add to that sometimes functional assessment. Depend on, because that will be the last part. I already took history from the patient. I already examined the patient. Now, when I finish my examination, in my mind, knowing the prognosis, recovery, and the current functional level and the current exam finding, is the patient has a potential to do 1, 2, 3, 4. I try sometimes to ask the patient to show me the potential if he's capable of doing so. That will help you to improve your accuracy of goal setting and understand if there are barriers to achieve these goals. Transfer, if you think patient should be, is having weak lower limb, but very strong upper limb, you expect this patient should be able to transfer independently. When you ask the patient to start doing the transfer, sometimes you will identify something else like anxiety. Patient will be very anxious, or same things when the patient has a reasonable power in the lower limb. When you ask him to stand with the help of a walker, you find he's very anxious, sweaty, and that's very important, crucial to know, to address it, because otherwise, if you don't address it, just go with the history and exam finding, and you think that patient has a potential to do so without assessing, as an example, anxiety. If a patient has severe anxiety and you start admitting the patient because you believe he has a significant potential and they found he's anxious, nothing can be done, took them another 2 to 3 weeks to manage it, and maybe he got discharged before the medication used to manage the anxieties start working. You delay and you impacted everything. You impacted the system. You delay the patient's recovery and also the confidence of the patient, because he tried, he failed. The second time after the anxiety gets managed, he won't be as confident as the first time. For that reason, most of the time, I like to add the functional assessment in the clinic to know the patient potential and to validate my history and exam finding and to add it to the patient's potential. And any questions, comment on these slides, because I believe this is the crucial slides I have today. Okay. It's very important when you plan a patient's care, when you have history and exam, to keep in mind the nature of the disease. Is it a progressive versus static? Because fluctuating, stable, like relapsing, remitting, if there is a sensory involvement, patient may have a good power, but sensory ataxia is the main barrier for him to achieve the function. Fatigue are the main barriers, because all these important to keep in mind when you try to plan the patient rehab goals. Sometimes, for example, I'll give you one example of a patient who has a myopathy, Duchenne myopathy, is having difficulty with ambulation, and you are prescribing for him a wheelchair. At that time, when you are writing the prescription or asking the OT to write a prescription, he has a functional upper limb. But we know in our system, the wheelchair delivery takes sometimes 6 months or longer. And we know the disease is progressive. And it will be very difficult if you get one chair next time to get another chair. So from the beginning, we plan for a power wheelchair rather than waiting for this condition to get worse and patient to become eligible or cannot get the appropriate wheelchair for him at that time. That's just one example, but always keep in mind the nature of the disease when you are putting your rehab plans. And as I said, The goals depend on the disease type and stages, and what stage the patient in. Function impairment is crucial, prognosis, and what's the patient priorities, and rehab team and patient participation. All these are important for you when you try to write the goals. You have to know your team capabilities, and there are borderline goals can be achieved, but you may need highly motivated expert therapists to achieve these goals. And if you have an average therapist, these are a potential goal but cannot be achieved at this stage due to the limitation of the team. Other limitations, sometimes patient participation, patients having anxiety, depression, having unrealistic expectation, like he would like to walk, he's not interested in to be independent in dressing. All of that very important to keep in your mind when you're planning your patient rehab needs. As I said earlier, functional impairments and the goals. I just remember a case I had last week. Patient who have charcoal tooth for many years. It's progressive, progressed to the point where lower limb power is around 1 to 2, but he has really good upper extremities. And his functional level that he's totally independent in all ADLs and transfer and wheelchair mobility. For most of us, we believe if he has weak lower limb and strong upper limb, that is the expected function level for this patient. When we ask him, what are the limitations you have in your daily life? He told me that he liked to play cards with his cousin, and he cannot sit on the floor. He has to be seated in a wheelchair because he has a limitation with a knee flexion. And for that reason, all of his cousin has to be on a chair, and they have to bring a table. And that's the main barrier for him to be actively engaged in the socially. Unless we ask open-ended question, we will not understand these limitation because from FIM score, he's doing everything by himself, but patient has some limitation that's need to be asked the right question so he can express it. Okay, now when do you consider inpatient rehabilitation versus outpatient rehabilitation? I want to hear your thoughts on this. Who needs inpatient versus can be managed as an outpatient?
Assalamu alaikum, Doctor.
Assalamu alaikum wa barakatuh.
From my point of view, it depends on the functional level. If we have, it depends on the functional level and depends if it's an acute or in a chronic setting. For example, if we have lower FIM score in all aspects, patient will benefit potentially from inpatient, from the extensive sessions. But if we found that patient is modified independent, that we need supervision, outpatient would be an optimal for him, except for some cases, especially in acute setting.
Okay, excellent. Another thoughts?
I think sometimes for social reasoning, if the patient is living in a peripheral city and they have no well-established service there, although his case can be managed as outpatient, but we prefer to admit him to just get everything done. Maybe he just needs only 1 week of inpatient rehab. But if you keep patient following, you will struggle to come to our central city and he will not he will get far appointment and deteriorate till he get next follow-up, because sometimes you have a busy schedule in the clinic.
Okay, that area is controversial and still not yet. I mean, we talk about inpatient in general rehab, not only in Saudi in general as a practice. Some country they do believe the social reason should be added as one of the reason to justify admission. Some still it's not one of the areas to be addressed. Many, by the way, when you talk about social reason, many facility, they do have collaboration through a social worker with some housing, and that can be addressed alternatively. But that area, I think it's case by case and depend on the situation. Okay, any other thoughts, comments? I see some chat here.
I think most important cause is if patients still need like medical supervision. This is the main cause for admit patient for inpatient rehab. I mean, in general. But
Okay.
actually, during our work, it's not like this one. We have
Yeah,
many causes before medical cause.
Yeah, that's the debate when insurance company always they like, okay, patient doesn't need the medical supervision. That's why he should not be admitted as inpatient, and his service should be outpatient. Actually, as a summary, because if you read different criteria for admission, each facility, each country, each policy, they have detailed criteria, selection, and exception criteria, exclusion criteria, I mean. But the statement, I believe, is summarize all of it. When a patient has realistic goals that can be achieved within a reasonable time, when we say a reasonable time, usually in the rehab, we're not talking beyond 8 to 12 weeks, that cannot be achieved as an outpatient. Patient must have a realistic goal that can be achieved within a reasonable time, and these goals cannot be achieved as an outpatient. That patient is a candidate for inpatient rehab. But if he has a realistic goals that can be achieved as an outpatient, then that's not an inpatient rehab. If he has a realistic goals that cannot be achieved within a reasonable time, that's not an inpatient patient. But that's in summary of what I believe it's the core of inpatient rehab justification. When it's come to outpatient rehab, it's also as important as inpatient. When you have a patient and you refer him to the outpatient different therapist, many times we see a referral without specific goals. We as a PM&R, as I said earlier, we should know the patient history, examination, potential prognosis based on our knowledge expertise. And we know the capability of different rehab discipline. We should set the goals for patient referral. Patient refer for physical therapy, patient for gait training to be modified independent with gait aids. Unless we have a specific goals for them, the patient will be in a virtuous cycle. They will go to a therapist. They will come to you later on. The therapist may work on something different than what you believe the patient has a potential in improving. And that's why it's important for the outpatient rehab setting to have realistic goals with a clear, smart goals for the different discipline when you refer the patient to. And that plan has to be conveyed to the patient. The patient has to understand why he's going to see the different discipline, what to expect from different discipline. That will help patient engagement and understanding why he's going at different therapist. And when we share a patient with the goals, I like the statements, always under promise and over deliver. If you think a patient has a potential, to walk with the cane, but most likely 90% he will be able to walk with the walker, but 60-70% he will walk with the cane. Do not promise the cane, promise the walker. We say, okay, we will help you to achieve independence in ambulation using a walker. If you achieve better, that's great. But if you achieve a walker, at least you're still gaining the patient's trust and confidence in you. Always under promise and over deliver, even when it comes to the rehab goals, upon your assessment and clinical judgment. Type, any comment, thoughts before we take a break? Type, Dr. Jamil, should we take a break?
Yes, please. Take break for 20 minutes and we'll be back inshallah at 8 o'clock.
وكذا بإذن الله. يعطيك العافية.
الله يعافيكم. جزاكم الله خير.
طيب, welcome back everyone. We were discussing inpatient versus outpatient rehab, and we said inpatient rehab should be exclusive for patient who has realistic goals that can be achieved within a reasonable time, and these goals cannot be achieved as an outpatient. وكان في discussion about the time since the injury incidents. I forget to just highlight on it. The time is important, but not always. Sometimes you may see a patient who had an injury years ago, but still has a potential. And sometimes you may also see a patient who did receive a rehab before, and he has potential that was not addressed before. All these factors, I mean, the time since the injury, the number of rehab, it's important, I mean, information to consider, but shouldn't be a solid no for receiving further rehab plan when there are potential for realistic goals. Type, what to do if you have limited resources? Why I put this slides, because I have received many referrals, and I see a comment on those referrals that which I'd like to highlight here. Many of us practicing at different facility, not all the facility has all the resources needed for patient care. Yet there are some resources. It's very important to address the patient's needs within the resources you have and refer to another facility for the needs that you do not have the resources to manage or deal with. Examples, what I've seen in my practice, a patient who have MS been diagnosed years ago, and the referral justification, we don't have a urodynamic for that the patient should be referred. I like to see, and I'd like to, be assured this patient still will continue the management for other concerns, will continue with the same provider. But as example, neurogenic bladder, neurodynamic, which is not available, can be managed at another facility, and then continue with the same provider for other needs. But unfortunately, I've seen sometimes referral, transfer of care. I won't say a referral for addressing issues that resources are limited. You may consult or refer, but continue with whatever you have. By this, patient continuity of care will be assured, and patient trust also will be assured. Type. I will highlight on maybe 3-4 major issues in the neuro rehab. Just a brief highlight and on the challenges that we face and how I approach them. Neuropathic pain is very common in the neurorehab population. And for me, it's very important to have an accurate assessment and assure this symptoms is related to the diagnosis the patient have. Because it's easy to blame the diagnosis for any symptoms may arise in the future, which is irrelevant. Patient may have neuropathic pain and new weakness due to peroneal nerve neuropathy, while the patient has multiple sclerosis. And if you dig deep on the history, you find this patient has a disease for many years, stable course. Only a few months ago, he's developed these symptoms and weakness. Why am I highlighting here? Because sometimes we start the treatment without digging deep into the assessment and making sure the patient's symptoms is related to disease patients now to have, or the patients need to have further diagnostic workup if it doesn't match either the history or the exam finding. And another issues when we talk about neuropathic pain, it's very important to get detailed history because neuropathic pain symptoms may mask other nociceptive pain symptoms. For that reason, it's very important to make sure it is neuropathic pain, not other source of pain. In addition to that, the character of the pain, the gabapentoid and the evidence that other tricyclic and other medication that's available in the algorithm for managing neuropathic pain are good to treat numbness, tingling, shooting, hotness, all of that. Sorry, tingling and hotness and electric-like sensation, all of these symptoms. But when we talk about numbness, it's a very challenging to ask the question, and it's very challenging to distinguish between numbness and tingling. And it's always important to know if it's the patient's symptoms that he's having, it's a numbness or tingling, because tingling medication will work on. Numbness, it's very unlikely that the medication will work on. And I always like to give a patient example because both numbness and tingling for patients, it's a new terminology most of the time. And it's difficult no matter how I explain what do I mean by numbness, what do I mean by tingling. But I give an example. Have you ever been to a dentist and when they freeze your tooth, you feel your cheek numb? That is a numbness. The tingling is when you cross your legs and you feel there is tingling in your legs. That's a tingling. Is your symptoms more of a numbness or tingling? When I give these examples, most of us had experienced one of these. Patient will understand and can accurately report if he is having numbness or tingling. If he reports it's numbness, the medication has no role, and that's why we should not consider the medical treatment. We should go with biofeedback, counseling, assuring the patient about these symptoms. The reason I highlighted this is an area or an area for discussion because many times I have patients in a high dose of pregabalin and still reporting numbness or symptoms are not improving. When you dig deeper, I found it's a numbness. We start tapering down the medication and the symptom does not change. And when he's assured and we explain to him the symptoms and how we can manage it, they start to understand and they will be accepting. I won't say it will disappear, but they will be accepting. The second dilemma that always there, especially over the last few years, when pregabalin start to have a value in the market, on the street. 10 years ago, no one ever heard of pregabalin or Lyrica, and it has no value on the street. But for some reason, over the last years, people abuse of Lyrica are increased, and it's becoming an area of struggle most of the time with my patient. And the evidence and the experience, when we talk about therapeutic effect, I haven't seen a significant difference between pregabalin and gabapentin. The main advantage from my perspective for pregabalin versus gabapentin, I can reach a reasonable dose within a shorter time. I'm tapering, take shorter time. I can start with 75 within 6 to 8 weeks. I will be at 150 BID or 300 BID, which is the maximum dose, while gabapentin takes longer time to reach high dose. That's the main difference. In terms of the efficacy, myself, I haven't seen a significant difference. And my approach now, always I consider gabapentin as a first choice, and pregabalin is a first choice only for those who I do not think they are at risk of pregabalin abuse, and those who are a potential of pregabalin abuse. From the beginning, I start with the gabapentin without going into the dilemma of stopping prescribing, double prescribing. That's the first thing I would like to highlight and share with you. Second is the importance of aerobic exercises for neuropathic pain. We always overlook that, and we go with the only medical management. All evidence show that exercises increase the pain threshold. So the patient's need for medication reduce if they are active, increase if they have limited activities. And in the neurorehab clinic, when I manage patients with neuropathic pain, I start with a gabapentoid or tricyclic antidepressant. I start to go usually with a single agent. If it's not effective, I add a double agent, and still, when I reach a high dose, and still not effective, and I find the patients need to go to the third line, an opioid, I always refer to pain clinic. Why I do refer to pain clinic? Because that's an area also, it's a challenging area, and it has to be provided when, in a controlled system. Most of, or many of pain clinic, they start patient contract. What do I mean by patient contract? They sign a contract with the patient. We will be the primary prescriber for your opioid. If we discover that you're getting opioid from another source, you will be discharged from the clinic. At least there is some regulation and control to minimize the risk of abuse. That's why, since we don't have that system in my clinic, and we are not the primary specialist in terms of pain management, I prefer to refer patients, whomever need opioid, to pain clinic, because most of the time those patients will need it for a long time. We talk about years, and it has to be delivered by a professional team who has the setup and the system to minimize the risk of abuse. Any question, comment about the neuropathic pain approach and management? Fatigue is very common symptoms, not only in MS, but it's more disabling and prominent in MS. As you know, it's a multifactorial. Many times I discover depression is in the underlying or behind this depression. Sorry, I see a comment here. What's the difference treatment for numbness versus tingling? Tingling, we treat it similar to other neuropathic pain approaches, while numbness medication has no role of starting medication for numbness. And numbness, we go with desensitization technique and patient counseling and assurance. But I do not prescribe medication for numbness, only for tingling and other symptoms of neuropathic. Type. Depression, always is important to look for depression. And it's how to ask the question about the depression is more than, because most of the time we ask a patient, do you have depression? Many patients, they will say no. Because it has a stigma. Some of them, they believe there is a stigma. And I ask also open-ended question. We know sometimes it's difficult for anyone on your situation. How is your mood in general? Do you have difficulties or anything? Then they will open. I start to validate to the patient, it's okay to have a low mood before I ask him that question. And that they open up. And the same things when I try to counsel them about the referral to a psychiatry, if they have the symptoms. Many patients, they refuse the referral, but I approach it same way. Okay, sometimes we go through difficult situations. We have issues with the mood. And then sometimes we can manage that ourselves with the support of friends and family. But sometimes these symptoms are severe enough where we cannot overcome it ourselves and we need help from others. Do you think you need help from others? Many times they say yes, if I ask that way. But if I approach it, okay, do you have depression? Yes, I will refer you to psychiatry. They will reject. But we need to ask the question the right way and also offer help in appropriate manner, validating their concern, validating it's okay to get a psychiatry assessment and management. Sleep issues contribute significantly to fatigue. That's why always we have to look into sleep. Sleep issues, I find it, for those who have moderate to severe disability, is a major issue here, especially in our culture. Most of those patients, they have, because they are not working, they have bad sleep hygiene. Most of them, they sleep in the morning and they wake up in the evening. And that's an area for addressing and managing and counseling with the patient. And also, many of neurological diseases associated with obstructive sleep apnea. It's also important to ask for obstructive sleep apnea symptoms. If patient has symptoms, we need to refer to sleep medicine to address it. In addition to that, when we discuss the fatigue and patient who has fatigue, we need to address their physical activity, and if we can minimize energy expenditure for them to perform the activities. Patient who has food drop or patient who have some balance issues, they are not relying on gait aids or orthosis, and that's consume more energy for them to perform the task, and it's easier for them to get fatigue. But if you minimize the energy expenditure during their mobility, the fatigue symptoms may reduce. Assisted device and orthosis, just the highlight here, early use can prolong independence. I've seen many patients who are a good candidate for type of devices, orthosis, but because they never offered these orthoses for many years, when they come to me, when I offer it and they try it, because they will not be a functional user of these orthoses, because they adopt in a way, maybe it's not healthy, maybe it's not good for their function, but it's too late for them to learn and to accept using an orthosis or gait aids. While if we catch up that patient early and we give them the appropriate orthosis or gait aids, most of the time they will be performing functionally way better than the current function level for this patient. And also, it's very important for a patient to understand why he is getting these devices. So in the future, when he comes for follow-up, when you ask him that question, if it's helping or not, if he doesn't understand why he's getting these sources or devices, he will not give you an accurate answer if it's helping or not. For that reason, it's very important for a patient to understand why he's using these orthoses. Are these for active goals or passive goals? If it's for an active goals, what exactly the goals you're looking for? So when the patient uses it, he will report back to you if it's achieving the intended goal or not. Again, it's important here when we prescribe an orthosis, I always tell my patient there are different type of orthosis, different material. We believe you need it, but if it doesn't fit for a reason or another, it doesn't mean that you don't need it. You may need a different one, a different material, a different design, but it doesn't mean that you do not need an orthosis. Like all of us, we need a shoe to walk outdoor, but if we have uncomfortable shoe, we do not throw it away and walk barefoot. We always look for a different shoe. I try to give these into perspective so patient can report back to the orthotist and report back to you if they have an issue and modify and address the concern they have with the orthosis. If we do not discuss that early on, you will see your patient months later, he received the orthosis, he had an issue with it, he threw it away, and he's still functioning without using the orthosis. And very important to address falls. Falls is emergency. I had many patients, unfortunately, who had falls resulted in a significant injury. And studies show that those who are ambulating with some difficulties, talk about like they are barely able to walk with the orthosis and the help of a walker. If they have a fracture that's needed at least like 2 to 3 months to heal, most of the time those patients, they will lose their ability to ambulate after they recover from those injuries because they cannot relearn the compensatory strategies they used before to ambulate. For that reason, it's very important when they are at risk of falls to address that early and refer them to the therapist and make sure the patient understand the risk. It's not only about the injury or fracture. In addition to that, they may lose their ability to ambulate afterward. Neuromuscular scoliosis, I put this here because most of the time when we see a patient who have a scoliosis, we treat it like an idiopathic scoliosis. Neuromuscular scoliosis approach is totally different than idiopathic scoliosis. Idiopathic scoliosis management in a growing skeleton is different than neuromuscular scoliosis. For that, the management here, we try to, regardless of the cups angle, we manage it with the appropriate seating system, minimize the symptoms, plus or minus orthosis, TLSO, or others, to minimize the symptoms and not to minimize the progression of the scoliosis because it's progressive. And the only treatment for neuromuscular scoliosis is surgery. So if patients who are in need for treatment, either patients positioning becoming a challenge, or patient at risk of compromising lungs due to scoliosis, surgery can be considered even early on, even if the cups angles 20 or 30. But it's very important to know neuromuscular sclerosis, it's not similar to idiopathic scoliosis. Sorry, I'm not really following with the chat. Maybe I'm not good. I'll see if we have a question.
Dr. Ayman, if you can, excuse me, how we can differentiate between idiopathic and neuromuscular from our clinical assessment?
Oh, by definition, idiopathic scoliosis is a patient who have a scoliosis and no clear etiology. I mean, that's why patients who have a scoliosis early on as a child, we need to do a full neurological examination, full assessment to know if he has a neurological disease or not. If the scoliosis is secondary to neurological diseases, that by default is a neuromuscular scoliosis. If it's only scoliosis without any other diseases, that's not idiopathic scoliosis. And for that, the approach is different, positioning, seating system. And if patients who need a treatment, surgery is the only treatment, not the braces.
I heard about one technique which is very common in Germany. They call it a Schroth technique. I don't know if it's applicable here in Saudi, but from the evidence, it showed a good outcome in terms of correcting the cup angle. But unfortunately, there is no data, especially here in the Middle East and Saudi.
And they are talking about idiopathic or neuromuscular scoliosis?
Idiopathic.
Yeah, okay. Idiopathic, there are different management plan, intervention, different technique. There are some role for manual therapy to reduce the cups angle and orthosis to stop progression. But the neuromuscular, as an example, Duchenne muscular dystrophy, evidence shows almost 100% of patients with Duchenne, they will have a scoliosis. And that varies from one diagnosis to another. Constipation, it's a very common symptoms in the clinic for patients with in the new rehab clinic. And many times I discover patients who are constipated, they do have a neurogenic bladder, and as an avoidance for incontinence, they avoid drinking water. And because they are not drinking water, they will be constipated. And we are using softener most of the time because that's the first step in management. And all of us know that softener won't work if there isn't a good dehydration. For that reason, whenever a patient who has a constipation, do not forget to go back and ask about the neurogenic bladder symptoms. because I found it in my clinic very commonly associated. I had patients who only drink maybe half a bottle of water a day because they are avoiding leakage, and they are severely constipated because of that. In addition to the neuronic bladder, it's always important to address it because it's usually or frequently it's one of the reason for social isolation to avoid any situation where they have incontinence or leakage outside. But the main message here and the things I found in the clinic, many constipated patients, they have neuronic bladder symptoms and they avoid to drink to avoid leakage. How we deal with a patient with a complex need. Sometimes we have a patient in the clinic, maybe it's their first visit, they have chronic disease, been a while, they haven't seen a physiatrist before. When you see them, you find there are a lot of issues that you need to address. Hygienic bowel, bladder, neuropathic pain, psychological issues, social support, mobility activities, community reintegration, some rehab goals that they have a potential to achieve. And it's very difficult to approach those patients. It's not only it's time consuming, which at the beginning I felt that's the main challenge for those patients because they do have a list of 7, 8 concerns or issues. It takes time to address it all. But I discovered later when I try to address it all in one visit, none of these will be achieved because it's too much for patient or patient family to comprehend the management plan and follow the management plan. And you will see them again in a follow-up, and nothing of what you have discussed and planned has achieved, or some of it might be achieved, but not the way you explained thoroughly in the clinic. For that reason, try to address what you think it's most important and what the patients believe it's most important during the first visit. And the second priority, keep it in the follow-up visit. So by this, you will have a priority and a clear plan. Patients and patient family, they can follow up with your plan and they can leave a clinic with a clear understanding. Because if you give them a lot of information, a lot of plan, no matter what's their level of education, it's difficult for them to comprehend and follow it. What's your approach for a difficult patient versus patient in a difficult situation? Any thought?
For difficult patients, it's important since day one of rehab to have a patient meeting or family meeting to discuss all things related to rehabilitation plan. What is the important things to be done during this admission? What is the prognosis? The importance of compliance and the possible complication of non-compliance, to give him a clear picture about expectations and discharge goals.
Excellent.
For patient with difficult situation, that will depend on the facility. Is it providing all allied medical healthcare, all subspecialties. So the answer it will depend on the center, to be honest.
Excellent. Thank you so much, Doctor. And anyone else would like to share their thoughts? Perfect. I agree with the difficult patient, but the main things I would like to highlight here, most of the time, they are the same. Difficult patients are patients who are in a difficult situation, but we perceive them as a difficult patient most of the time. I won't say all the time, but many of those patients who we perceive them are a difficult patient, they're having a difficult situation for a different reason. They are in a difficult situation. It could be related to misunderstanding of their disease, or they have misbelief, and for that reason they have unrealistic expectation. They have a bad previous experience, and they are judging all of us the same. They have family or community pressure for them to get better or to go elsewhere to receive treatment. Burnout of the caregiver, that's another reason they are becoming difficult. And systemic issues, lack of supportive resources. We know that we have a difficulty with the social support, difficulty with the system, connecting the different facility, referral, all of that. Patients may express these challenges differently. They may express it in a very frustrated language, in a very sometimes aggressive language. I won't say that's acceptable, but it's very important for us to understand why they seem difficult. If you approach him with a mindset that you're trying to help them, you will know exactly what's the trigger and why they seem difficult. If you approach him with a mindset that you are defensive, you're not expected to say that, you should not do this, or you should not do that, and you try to be, judgmental on their attitude, they will continue with this behavior, and you won't achieve much with those patients. From my limited experience, I would say more than 90% of those patients, when I hear them out, you understand there is either a misbelief, misunderstanding, they had a previous bad experience and they are judging everyone is the same. Sometimes everyone is putting a pressure on them. They should go abroad. They should be admitted at your facility. And you're telling them you don't need admission. When you try to explain to the patient why they do not need this treatment, why this approach is not appropriate for them, you're not explaining it to the patient only. The patient is the recipient, but when he goes home, he has the family or the community pressure. He has to be either advocate and explain to them why it's okay to accept whatever you told him, or he will follow their recommendation and come back with a complaint or concern. That's the reality, because we know in our community, many people interfere with others' plan, management, give advice, recommendation. Not only advice, sometimes they give it in a way that you have to do so and so. Keep in your mind all of these cultural and community challenges and pressure put on the patient when they come to you. If you have this in your mind and you have a mindset that you're trying to help the patient, and you open up, you listen to the patient, you understand why he believes this approach is what he needs, why he believes he should be walking, why he believes his son should be walking. Just ask these questions. Why you think this should be done? Why you think that should be done? They will open up and they will give you the information that you need, and then later on try to address it and explain it in a way that not judgmental, but you're trying to help them. I won't say all the time they will leave smiling and satisfied, but they will leave trusting you, even if they have a pressure from the community or so. Still, some of it will be reduced. If they're tone at 90%, they will leave with their tone at 60%. طيب, any thought, experience, someone would like to share experience? Because I do have a lot of stories about those who are perceived are difficult patient, but approaching them differently, they leave with an understanding from our perspective. They have a difficult situation, and we were able to help them to address their concerns differently. But I will leave this discussion probably to the end. Tfadal, anyone will say something?
Just to add, one of these reasons is language barrier. Majority of our nurses are not a native Arabic speaker. So the patient or the family cannot be understood. So once you sit with the family, with the patient, just listen to them. Most of the time, you will find it's just a simple thing.
Yeah, excellent, excellent. This is very common on a daily basis, maybe. Excellent. Thank you so much, everyone.
There was one patient who have mild cognitive impairment and memory issues. And with every weekly round, there was a challenge to provide and repeat the same management plan and what is the expectation of rehab. So the solution was to write it on the paper and hang it in front of the patient. And it was effective.
Excellent. He wasn't difficult, but he had a memory issue, and you understand it and resolve it. Excellent, thank you.
Yeah, it was thought and perceived before that he was a difficult patient, but after detailed assessment, it turns out that he has a memory issue. That's why.
Excellent. That's a good example. Thanks a lot. Thanks both for sharing your stories. And the message here, if we have that in our mindset, difficult patient, let's try why he is difficult, as let's try to help him. Most of the time you'll come up with a solution and your patient outcome will be better. In conclusion here, remember, neurorehab is not more than a recovery. It's about re-empowering lives, and it's always important to look at all aspects of patient life when we talk about post-discharge, when they reach a maximum expected potential recovery, community participation. What are the barriers for community participation to help them to return back to the community? Because that's the ultimate goal of rehab. If we do not address that and work on it, we haven't achieved what's the rehab potential and expectation for those patients. Invest in improving your communication skills. This is very, very, very important. I had many communication skill courses. I will say the second most valuable investment I had in my career after my board and fellowship is my communication skill courses. It is needed at every aspect of your practice, relationship with your patient, colleagues, and all of that. You are the first person who's gonna feel the impact, not only others. And for this, I highly encourage everyone to invest in improving their communication skills, attending courses, getting a feedback, or any other approaches that help you to improve your skills. Improve your biomechanic knowledge, available rehab intervention, and new treatment options. It's very important when you assess the patient, especially when you talk about function and mobility, having a good knowledge about the biomechanics will also give you a better understanding of a patient potential. Also, you need to know each discipline, rehab discipline role, available intervention. If you have a complex case, you need to have a good rapport with a different rehab team, so you can approach them and ensure that a good therapist for this either complex or borderline cases handle it with the expectation you're having. So having a team, not only a formal, I'm saying, okay, you have to build a network within your facility, so to maximize your patient's potential outcome. Keep yourself updated, especially in the world of neuromuscular in general, because over the last 5 years, there is a good advancement of a different type of therapy, especially gene therapy becoming, promising to those patients. So you might have a patient who's been following with you for years, and he's not seeing a primary neurologist because these diagnoses usually doesn't need to follow with the primary neurologist. Make sure that you are updated with these diseases, so you can refer a patient and get the appropriate get the access to the treatment. Always, rehab physician has to be an excellent at prognosticating the patient's recovery, and improve your prognostication skills by continue reading about different diseases, prognosis, exposure. Follow your patient. You have to see more patients at different spectrum of patient journey. You have to see patients during their acute illness while they are receiving active medical management. Try to see those patients while they are receiving the subacute rehab. And the more you follow them as an outpatient and the more patients you will see, your prognostication skills will improve, and your accuracy of writing a treatment plan and rehab goals will get better. And at the end, as a PM&R physician, we must drive research, because in the field, there is a lot of area for improvement and lack of evidence at many approaches that we're doing. So encourage everyone here to participate in the research and be advocate for your patient, for access to care. We have a lot of patients who are struggling and their rehab needs not being identified. You are the patient's advocate to get the patients the appropriate service and access to the appropriate service at the appropriate time. And we have to be adaptive with the new technology and keep in our mind and keep in our practice the humanistic core of our practice in the field of PM&R. With this, I'll conclude, and I'll leave the last 10-15 minutes for discussion and question. Thanks for listening.
Thank you, Dr. Ayman, for this informative lecture. I have just a question regarding recommendations for patients with fatigue, especially for work modifications. I think it's very crucial role as a physiatrist to include that in discharge or medical report to help and facilitate patient return to work. Unfortunately, I don't see that it's very common during daily practice, but I think it's very crucial and important, and patients will appreciate these recommendations regarding fatigue or weakness or tremor in general in patient in our rehab.
Right, excellent. Thanks for your comment. And I totally agree. Being a patient advocate, it doesn't stop just at counseling the patients. Writing a medical report with the recommendation addressed to their workplace or employer is very important. But the key here, we try to manage what's manageable as a fatigue, either if there is a secondary cause, as we discussed earlier, we manage it. When it comes to writing a recommendation for workplace, some modification can be specific and exact. Like when you talk about vocational counseling, they do a detailed assessment for a patient, and they will report to you the specific details about patient's functional ability and limitation. But when it comes to fatigue, we cannot be very specific. Okay, can the patient tolerate 2 hours or 1 hour? And that's an area where it's very important to advocate for our patient. But in the meantime, it's very important not to guess, because if you become back and forth between the workplace and you as a primary, justify why 3 hours, not 2 hours. Justify why 2 hours, not 3 hours. We do not have a clear guideline with that, but writing it as a general statement, I highly recommend patient who has this diagnosis, and fatigue is one of the well-known symptoms. For that, we expect his employer to accommodate his needs, understanding he is at risk of having fatigue, without giving a specific recommendation. Because specific recommendation without like a solid baseline may not help the patient.
Thank you, Doctor. I have this one. I want your opinion regarding using steroid in acute neuropathic pain setting, especially with Guillain-Barré syndrome, as an adjuvant therapy with the non-pharmacological and pregabalin.
Okay, I haven't done it, I haven't seen it, and I haven't seen any evidence for that. Unless there is something emerging this year, I'm not aware. But I haven't seen any of the neuromuscular colleagues using it before. And I haven't seen any evidence for it, unless there's something new you want to share it with us.
I can share my experience with the 2 patients who were young, and after waiting risk and benefits of low dose steroid in short term, it showed a great outcome. And my evidence was it was not a very big study, only multiple case reports, and I tried it with patient with GBS who was young, who was having allodynia, who was not participating well in rehab, especially during gait retraining and wearing shoes or AFO. And after a period of time, patient pain improved and functionality improved and gait distance increased, and he was tolerating socks and wearing shoes. But there was no big evidence regarding that, only a few case reports. And we can apply this with patients who is having complex regional pain syndrome, either primary or secondary, with taking highly precautions in terms of risk and benefits, especially patients with stroke.
طيب, the complex regional pain syndrome story is different because there is an evidence for steroid there. Okay, عشان بس we don't mix them each other. And use steroid with other medication, only steroid.
First, we used anti-epileptic drug, and it showed a minimal improvement. However, the pain was not improving fully. But after using small dose of steroid and tapering up the dose, then tapering down, the course was 3 to 4 weeks. And after discharge, patient, in the follow-up setting in the clinic, he returned to his almost normal gait pattern, and he reported no pain, and he reported improvement of quality of life in general.
Yeah, طيب, that's an excellent, and it's an excellent case report. You may share it with all of us later on. But again, time is also important when you consider GBS. There is a natural or expected time where the pain will be at most severe, and then it goes down as the recovery improve. Because when we expect some recovery, usually muscle power improve and neuropathic pain reduce. I'm saying, okay, if it's only 1 or 2 cases, it's good to keep it in your mind. And maybe it's publish it as a case report. Maybe others they also observe the same. Ruling out other factors may be the contributor for pain control. But thanks for sharing this experience with your patient. طيب, in the chat, Dr. Abdulaziz, can government news be abused? I only one time see a patient who are taking high dose, and that patient, he was taking it because his pain was not controlled, and he was taking it without medical advice. But I haven't experienced with patients who are using gabapentin. And increasing or tapering down the dose, usually it's depends on the patient's symptom severity and patient's age, comorbidities. If patient's young, usually and has severe pain, I can taper or increase the dose every 3 to 5 days, depends. I start with 300 or 400 at night, then PID, then TID, then I increase the night dose. Usually I try to target the night dose the first because the side effects of drowsiness, sleepiness happens with each increase. And if it's at night, patient already going to sleep. For senior patient above 60 or those who has some cognitive impairment, I go slower. I increase the dose not less than 5 days. Every 5 to 7 days, depend on the severity of the pain. طيب, Dr. Tamadr is rehab is all about neuroplasticity. Task-specific intensive therapy, learning how to achieve loss function in new methods and repeating it many times to optimize brain reorganization. And why you advocate for early rehab? Is that the
كنت أجاوب على أحد كان يسأل على
إيه أنا حاولت يعني شكرا لك إياس يعطيك العافية. طيب, yeah, can you say your comment because I don't know whom you're responding to.
بس أنا I was responding على موضوع neuroplasticity. I just wanted to comment إنه this is what we do. This is why we advocate for early rehab. إحنا نشتغل على هذه along with the functional recovery. I just added this to highlight this again.
طيب excellent. يعطيك العافية. شكرا دكتورة. Any last question before we conclude or comment?
Assalamu alaikum.
Salam.
There is a previous question about neuropathic pain or neurology pain in general. What is your opinion about using new advanced technologies, modalities like low-level laser therapy and magnetic field therapy and this type of therapies, even also transcranial magnetic therapy in neurological disease in general. This is because now is more advanced technology for avoiding using chemicals, medication like gabapentin and pregabalin and this medication, because these medications have a lot of side effects, while these other modalities, natural modalities, have less complication and less also precautions and less many or are in good can serve the patient better than drugs.
طيب, excellent. That's a good question. There are many modalities, emerging modalities. Examples you mentioned, transcranial magnetic stimulation. It's been there in the field for more than maybe 15 or 20 years, but limited researches. Lately, we have seen emerging research evidence for some of its use, but still haven't seen it as a replacement for the oral medication. None of these modalities can be as a replacement for the oral medication. And again, remember, neuropathic pain, it's not dangerous by itself, but we are treating the symptoms. We are treating these symptoms as the patient's report impacting him or her life or sleeps. If patients has a neuropathic pain, does not impact patient's daily function or doesn't impact their sleep, we don't have to treat it. If it's impacting any of these, we treat it because the negative impact of this pain is always severe and may affect others, mood, fatigue, and community participation. The message here, modalities not yet proven to be a replacement. It can be added as an adjuvant, but if we achieve good pain control, that's what we're aiming for. Then we taper the dose as long as the patients tolerate the pain that he has.
Okay, thank you.
Do you advise? My recommendation, duloxetine is one of the options for management neuropathic pain, but when you look at the algorithm for managing neuropathic pain, like the one published by the Canadian Society, they try to put the first line if the tricyclic plus or minus gabapentoid, but it's one of the options to treat neuropathic pain. And it depends on the patient's symptoms, and sometimes if patient has multiple symptoms, you may choose medication that helps neuropathic pain and other symptoms like tricyclic antidepressant. If patients having difficulty sleeping at night and having pain, maybe it's a good option to start with. طيب. The role of community reintegration, it's the role of each rehab discipline. The facility itself, it's not the primary responsibility. They have a role of advocating and facilitating, but before we consider what's the role of the facility, always we need to think of what's our role, because each patient's barrier for community reintegrations differ. So it has to be tailored for each and every patient, the plan advocacy. So whenever you have a patient, based on his or current ability and disability and barriers, you need to address it. So to enhance community reintegration for your patients. We promise you we finish at 9. ما بعد أعطلكم. It's almost 9.
Okay, thank you.
أشكركم
Thank you,
جميعا
Dr.
صراحة.
Ayman.
Thank you for تفضل.
Thank you, Dr. Ayman.
الله يعافيك. الله يعطيكم العافية جميعا. Thanks for your joining us today. Thanks for sharing your thoughts and your very active interactive discussion. يعطيكم العافية جميعا. Have a good night.
جزاكم الله خير دكتور، الله يسعدكم يا رب. And thank you all for your patience and commitment. Inshallah, see you in another webinar. Stay safe and have a good night. Thank you so much all. جزاكم الله خير دكتور أيمن.
شكرا لك دكتور. الله يعطيك العافية.
الله يعافيكم.